So thank you so much to Dr. Kim, Dr. Hofstetter for giving me this opportunity. It's great to give this talk in front of the people who taught me how to do this, Dr. Hofstetter and Dr. Harrison Kim, who's in the somewhere in the stands. So I'm here to talk about Uni-portal endoscopy and talk specifically about technical pearls from novice to ninja. And as you'd expect, there's definitely a lot more pearls for someone who's just getting started than for a ninja. So I'm really going to focus a lot more on the novice part than on the ninja part. These are my disclosures here. And before going into the specifics, I wanted to, I looked up online, what is a ninja and what is a novice? That wasn't a title that I chose. I think you chose that probably. And on this website, this random website, it showed a kind of a stepwise approach to what is a novice and what is a ninja. And I thought that was really great. So if a novice, you could do a very basic job, but you need help and guidance on tap. And then a ninja are really the people that are pushing the field forward. So again, I'm really going to focus more on the novice part because I think that's where most of the technical pearls are relevant. And we saw some great cases here from Dr. Jensen that demonstrate some of these. So really the most important thing, and we're going to go through these much more closely, is choosing your cases wisely. That's how you can set yourself up for success as you're going through the learning curve. The second thing is do those pain procedures. You saw Dr. Jensen and the outcome he had from that patient that was a horse rider. Do those. Maintain meticulous hemostasis. I never have a field that looks as good as his. It's always a bloody mess, but these are things that you could do to help with making your field look that way, because that minimizes complications and minimizes how tired you are during the cases. And as long as you're safe, you want to go to standardized endpoints. So he talked a little bit about how do you know you're decompressed. That's a big challenge when you're first starting, and there are some things there that we'll talk about that can help with making that decision. So choose your cases wisely. Have a team, whether it's from industry or someone who taught you or people that are further ahead in the learning curve, about what is a good case to start with. Am I ready to do this case? And this is a great example or great figure here. You want to start with the cases that are in the green part of that square. Don't start with the ones in the red. You're aiming to get to the ones in the red because that's where the biggest delta is between what we currently do at our current standard of care and what endoscopy can give us. But you have to work your way up towards that. And this is a great example here, and I think it's a great way of classifying what types of cases we could do initially before we move on to more complicated cases. So on that same note, do the pain procedures. Those are procedures that are on the green part of the figure that we had earlier, and those are patients that now you are sending to pain management. And those are patients that are in that gray area between what typically a pain doctor does and what typically a spine surgeon does. So you're not taking care of those patients anyway, but I do think that surgeons should be more involved in that gray area because those are our patients at the end of the day, and they trust us to take care of them the best way possible. So what am I talking about the pain procedures? It's these two procedures. So we talked a little bit in the last presentation about a medial branch transection. So that's really used for facet pain. But the second one is a sacroiliac joint denervation. So it's a lateral branch transection of the L5, S1, S2, and S3 nerves. And both of these procedures have great data about long-term success. And once you start doing these, you'll see that yourself. And again, you're enlarging your pie. You're not taking care of patients that you can already take care of with a tube or open. You're adding patients to your pie. And the best thing about this is that these are super low-risk procedures, so it allows you to get used to how do I hold the endoscope? How do I use the equipment? How do I maintain hemostasis in a way that is super low risk when you don't have nerves and crazy stuff in your vicinity? So pearl number 3, maintaining meticulous hemostasis. There's a bunch of things here that you could do to help with hemostasis. And all of these are being studied in the ESRG, the Endoscopic Spine Research Group. So we're looking to see which one of these, what's the most important in all of these. But these are all things that you could do. And the one that I wanted to focus on for a novice is whenever you have bone there, try to drill it. Don't bite it with a kerrison, because that's when you have a lot of times uncontrollable bleeding and you have that red screen that minimizes your ability to proceed with your case. And then the last thing is cauterize as you go, meaning sometimes you have to prophylactically use the bipolar to coagulate vessels before you bite that ligament, before you take that ligament off, because it helps you with minimizing the chances of getting that red screen. So pearl number 4, as long as it's safe, continue the operation until standardized endpoints. So what does that mean? So for a discectomy, this is a thoracic disc. For a disc, you want to expose the vertebra below and above the disc, as you could see here. So on the right side is the cranial level, on the inferior side is the caudal level. And I just go until it's flat. Do you really need to get to that to get a good outcome? Probably not. But when you're starting, you're going to scrutinize yourself very, very much and just make it look perfect. So by the end of this case, you'll see that everything is going to be super flat between the two vertebrae, and that's when you know that you are done. It's probably more than what you need to do, but when you're first starting, you need to make sure that you have perfect outcomes so that you can gain confidence, and then later on you can figure out where you can take shortcuts. So you see here how everything is super flat. For any type of ligamentous hypertrophy, you want to detach the ligamentum flavum rather than remove it piecemeal. So this is an example here of detaching the ligamentum flavum above and below from the cranial lamina and the caudal lamina. And you can see here on the picture on your left that you have epidural space above and below the ligamentum flavum before you remove it and decompress the spinal cord completely. And in terms of mediolateral, in the cervical spine, you look at where the exiting roots are, and the lumbar spine, like what Wade had in his presentation, you look for the traversing roots to make sure that you're mediolaterally decompressed. For any type of foraminotomy, you go pedicle to pedicle, just like you do for any type of open or minimally invasive procedure, whether it's in the cervical spine or in the lumbar spine. So those are I thought, the pearls that are the most important for someone just starting endoscopy without going too much into the weeds. In terms of for a ninja, so people like Dr. Hofstetter and Dr. Kim, it's important to stay current on newest technologies and learn from others in the field. It's very easy for us to be siloed into the company that we're working with and forgetting that there's other great people doing great work in other countries or in other companies. So it's important for us to keep that in mind and keep working with others to continue to get better. It's important to keep acting as a mentor to others just starting. And that's pretty much my talk here. So the take-home points are: choose your cases wisely, perform the pain procedures, because that's how you gain your endoscopic skills without within a low-risk environment. Maintain meticulous hemostasis so you can have a great field like what Dr. Jensen had. Look for your standardized endpoints, stay current on newest technologies, and act as a mentor to others just starting. So thank you all very much.